Test. Okay, you're now screen sharing live on YouTube. Okay, and whenever you're
Test. Okay, you're now screen sharing live on YouTube. Okay, and whenever you're test. Okay, you're now screen sharing.
Okay, as long as you see that it's live, that's good. So whenever you're ready, hit broadcast.
Okay, so how to get rid of that?
And this, I can just go through the questions with you.
No, just here. Put the key. Okay, so what I'm gonna do is I'll put the Q&A here.
Okay.
I'll scoot this over to a corner. Okay.
Here, why don't you just do this? Make it smaller like this. Doesn't all have to do that.
It's fine. I'll just put it over in the corner.
Okay. Okay.
Okay, so
whenever you hit broadcast, that's when you can go live.
Okay, so what I'm going to do is I'm going to, let me get back to, I'll put this over here.
Okay.
Again, I'll just remove it for now.
And then you could just.
I'll look at questions later.
Yeah.
Okay, so this is going to be my opening slide.
Yeah.
They're going to see me.
Mm-hmm.
I want to open my opening slide, which is this one.
You can just do this whenever you want to go back and forth, just so you know.
Yeah.
Okay.
But I don't know where the slides are because I.
Right. Okay. So
let's. Okay. You want to open up your computer?
Yeah.
I'll go broadcast. It's 7, right?
Yeah.
It is 7 o'clock. Okay. Yeah. Broadcast. Okay. Good evening, everybody. Let's see how many people we have here. We have 3 people, 4. We're going to wait till everybody gets in. We have quite a few more people signed up. So just sit tight. We'll get started in a few minutes with a short lecture, and I'll be answering your questions on anything to do with fertility or infertility. Depends on how you look at it. Evaluation and management. Okay. So while we're getting ready for everybody to come into the room, feel free to type in a question, and I'll be getting to your questions. There are going to be some polls that I'm going to take. I'm going to ask you some questions to answer as well. So we do have quite a few people signed up. I'll give it a few more minutes. So if anybody has to go to the bathroom, get a drink of water, go right ahead. I just realized that my
that's me.
Picture went out.
Let me get out of there. I'm using your account. Hold on.
Oh, so it's hang on, everybody. Maybe you shouldn't. Maybe not sign in.
Okay. There you
go. Okay.
See here, it pops up every time you have a question.
Okay. Okay. I think we'll just get started. We have 1 hour allotted. So today we're going to talk about the update on evaluation and treatment of infertility. We do have a few people already in the chat room in our webinar, and I can just jump to the first question. Somebody asks, does Clomid have any side effects? Well, one of the best side effects is getting pregnant. But what it does is Clomid actually helps to release extra eggs, or sometimes release 1 egg when a person doesn't normally ovulate. And it has a great pregnancy rate for those that do not ovulate normally. Okay, so, okay, I was going to try to get to a slide on that, and I can't. I think you need to sign out of that computer. Okay. Okay, hold on. I got a little,
I'm signed out.
I want to see all the slides. There they are. Okay, so let me tell you a little bit about Clomid. So somebody asked about this medication. So what Clomid does is Clomid makes women ovulate that don't normally ovulate. And so let's take a look at an ovary, for example. This is an ovary looking at an ultrasound. And as you see, you can see all these black little holes. Those are follicles on the ovary. This would be like a laparoscopic view of an ovary. And these are follicles about to rupture to release an egg. So Clomid makes those follicles grow and get bigger and bigger and bigger, and makes follicles release. Hang on a minute. Okay, so the side effect of Clomid is ovulation. Now, sometimes two eggs can come out. So someone who takes Clomid could have twins. So the chance of having twins is between 5 and 7%. Normally twins are 1%. So Clomid does have that side effect. Sometimes one of the negative side effects of Clomid is the lining of the uterus might get thin in maybe 10% of women. So we need to check that with an ultrasound to make sure the lining doesn't get too thin, because maybe the embryo won't implant well. But normally Clomid doesn't do that, and Clomid has a very good pregnancy rate. So let's just go back to the beginning. And as questions come in, I'll be happy to talk about it. So I'm Alan Morgan, Dr. Morgan. I'm a reproductive endocrinologist. I am in New Jersey. I don't know where all of you are from. I'm on the Jersey Shore in Lakewood, and I'm in Old Bridge, kind of central New Jersey. Old Bridge is probably about 30, 40 minutes outside New York City. So our objective is to talk about the causes of infertility, as well as different treatments. And we can talk about in vitro fertilization, artificial insemination, and other treatments. So let me jump into another quick question here. Okay, no more questions for the moment. Okay.
We have actually a few questions on email. I'll read it out to you.
Okay, we have a couple questions on email. Go ahead.
Okay, what typically tends to be the best treatment option for women with PCOS?
So for PCOS, the best treatment, so for those that don't know what PCOS means means polycystic ovarian syndrome. And
click the screen and do that.
So normally a woman ovulates every month. If a woman doesn't ovulate every month, maybe every 2 or 3 months, that's called irregular cycles or anovulation or oligoovulation. So the best treatment, that's the question, is probably the best treatment if the person's overweight is to try to lose some weight. Even 5% of the body weight loss will help that person lose weight. The next best option, if that doesn't work, is to try a mild fertility pill called Clomid. We just talked about Clomid earlier. Clomid has a ovulation rate of very high. In 3 months, there's about a 50% pregnancy rate, and in 6 months, about an 80% pregnancy rate. So the use of Clomid is really good, or letrozole, which is also known as Femara. These are very good drugs as well, and they have a little bit lower of a twin rate. Even though the twin rate is very low, it's only 5%, 6%, twin pregnancies do get complicated. So Clomid is a good entry-level medication. It's about $20, $30 to buy it. You only need 5 pills. And you would start during the early days of your menstrual cycle. So that's the best treatment. Of course, you want to check your blood to make sure you don't have a thyroid issue or any other things going on besides just having polycystic ovarian syndrome.
We have another 2, 3 more questions.
Okay, here, I'll read these questions. Thank you. Okay. Why is it necessary to have blood work done on the 3rd day of your cycle? So on the 3rd day of your cycle, is when everything just starts to begin. You have a bubble in your ovary called a follicle, and the follicle is about to grow, and it's very tiny. It's about the size of a little pea. And as it gets bigger and bigger, it makes more and more estrogen. So it's good to know what the baseline estrogen level is. It should be low. Also, the size of the follicle should be little. And it's nice to know what that is to begin with. Is it mandatory? No. You can do a cycle without the day 3 blood work, but it's hard to gauge what happens a week later when we do an ultrasound and blood work to see if the medication is working or not. So that's why we do baseline blood work on day 3. I have another question here. Should women in their late 30s attempt an IUI more than 3 times? IUI means inside uterus insemination. That's taking sperm and place it into the uterus, not an embryo. It's just sperm into the uterus. So should a woman in their late 30s attempt an IUI more than 3 times, or would you recommend they look into more aggressive treatment options after 3 IUI attempts if they're not successful? That's kind of an open-ended question here. I would try an IUI, but it really depends what the issue is. So an IUI is just placing sperm into the uterus. If the guy has a normal count or a low sperm count, you would try this, unless the guy's a really bad sperm count, like less than 5 million per milliliter, so per milliliter, that is. Okay, so if you're in your late 30s, approaching 40, you should think about in vitro fertilization sooner than later. And the reason is the pregnancy rate at 30 is, let's say, 20% per month. At 40, it's about 10% per month. But if you did IVF, it might be 3 to 4 times higher than that. So this is why people do IVF sooner than later, especially in your late 30s and early 40s. Let's go to the next question. How frequently do you visit the office if you're pursuing an IVF treatment? And what does cycle monitoring consist of during the IVF treatment? Okay, so let's talk about that. Let me talk about how many times it needs to be monitored. Okay, and I'm going to show you why. So if you look at, that's not the best picture here. Let's look at this picture instead. Okay, so as you see in the beginning of the menstrual cycle, day 1 here, and the days go by, day 14 is when most women ovulate. So in the beginning of the cycle, like day 1 or 2, we call it the follicular phase, you have a small follicle, and that's the egg inside. Then the follicle gets bigger. That's the egg, the black dot. And then it gets really big. This is a large follicle, maybe the size of a cherry tomato. And then as this gets bigger, the estrogen level goes way up, and then it triggers the brain to release this egg. So we don't know when all this is happening, if it's happening slowly, or too fast. So we measure the diameter of these follicles. And as they enlarge, we measure estrogen levels in your blood. And this is how we figure out when eggs are ready or mature to be removed through the IVF process, or if you're not doing IVF, when to gauge an IUI, that's placing sperm into the uterus, intrauterine insemination. So I hope that answered your question. Okay. Okay, here's another view of that. You see primary follicles. These are these little bubbles with eggs, and these get bigger and bigger until they rupture, and you can see an egg coming out. It's called an ovum. Okay. Let's get to another question. Everybody has questions. That's good. Why are women put on birth control pills for IVF? So when a woman goes on a birth control pill, what happens is, let's jump back to this picture here, the follicle stops growing. All the follicles kind of go into a state of no growth. They're supposed to, not always though. And that way, when you actually begin treatment, you're going to get more follicles around the same size to grow together so you can get more eggs later during the IVF process. So you get better egg removal or more eggs and which results in higher pregnancy rates. Okay, let's see. What's there to do when you have an unexplained infertility? Okay, well, unexplained infertility means the male has been evaluated and he's normal. The female has been evaluated and she's releasing eggs every month. That means she's getting a regular cycle every month, her eggs are coming out. She's had her tubes checked to make sure her tubes are open. And you know, show you. So, for example, this is a uterus, and the uterus, what we do to check that, we put some dye into the uterus, and the dye goes out through the tubes, and you can see this on an X-ray. You can see dye go out the left side and the right side, and that way you confirm that tubes are open. And the reason we want to do that is, if you look at the causes of infertility, you can see that almost a third of the time it's tubal. Look, and a third of the time it's the male factor. Ovulation issues can make up 15%. Unexplained is 10%. That's a lot. So there's a lot of women that have unexplained infertility. So let's get back to that question. So the question was, what is there to do when you have unexplained infertility? So after you've found out that there's really nothing you can identify, the treatment normally is to take a mild fertility pill or ovulation induction pill called Clomid. Clomid might release an extra egg or two, or it might correct a really subtle hormone problem that is not noticed by blood work or by your regular cycles. So Clomid makes extra eggs come out or corrects hormone issues that are not so obvious. Then the next thing is when your egg is coming out, to take the sperm, even if he has a normal sperm count, and you place it into the uterus, that's intrauterine insemination, that's IUI. So those are the two things that are most commonly prescribed for someone that has unexplained infertility. Okay. You try that maybe 1 or 2 or 3 months. And if that doesn't work, you can try injectable drugs, which is much stronger than Clomid. You might release 2 or 3 or 4 eggs. Now the pregnancy rates do go up, but now you're having a little bit of a risk with, you know, multiples. We don't want twins and triplets and quadruplets. Those are dangerous pregnancies because they deliver early. So we want to try to minimize multiples, but maximize pregnancy rates. Okay, I hope that answered your question. Is our office fully open now? Yes, it's fully open. Finally, we just opened a few days ago. And luckily nobody got the virus in my office, so we're all happy about that. Somebody asked me if I'm aware of certain religious laws and do we have religious patients? Yes, we do. We're in Lakewood. We have lots of patients and we work with the community very much and are very familiar with halakhic issues. Here's another question. How long does it take for a woman that wants to do IVF for genetics reasons? And is it possible to have more than one child? Yes. So the question is, how long does it take a woman that wants to do IVF for genetics? So first of all, we need to know what the genetic issue is. So for example, cystic fibrosis or eukaryotic cystic fibrosis, maybe you can type it in what the issue is, because they need to do what's called PGD, pre-genetic diagnosis. So once we remove eggs, they're fertilized with the sperm, and then 5 days later, your embryo is evaluated. A small sample's taken. It's called a biopsy. We send the biopsy to a special lab that does the genetics of the embryo. So that whole process could take about 3 weeks to create embryos from beginning to end, and then the laboratory could take another couple of weeks or more to tell us which embryo is affected and which embryo is not affected by this genetic problem. Okay, I have a question here. What is the latest treatment for non-obstructive azoospermia? Well, there is really nothing new in the horizons. When somebody does not have sperm, the best thing to do is to do a biopsy. This is called a testicular biopsy. Take a look and see what's there. Sometimes you will find sperm cells there. They could be mature or immature. They may not have tails, but this procedure requires, after the biopsy is done, if something is seen, you could do more of an exploratory type of procedure with a urologist. It's called a TESA, testicular, TESA, testicular epididymal sperm aspiration. So the testicle is actually opened, and the urologist will find certain areas within the testicle to evaluate and to sample, and it's done with a microscope in the room or adjacent to the room, and that person under the scope is usually an embryologist, and they will keep going through the samples that are given to him by the urologist to see if there's anything there to use to fertilize an egg in the future. Some people do go on medications a couple months prior to that procedure, say HCG shots or FSH shots, something to help maybe stimulate some sperm development. So that's what's happening with a non-obstructive. So that means there's not an obstruction in their vas deferens. Now, all the tubes are open, but there's just no sperm there. We have a question: how does an HSG procedure work? Well, I just showed a picture of that, and I'll go through it one more time. So this is a picture of, so this is a little cannula that's this is placed vaginally into the cervix, then dye, all the black is like dye, maybe a tablespoon or two. It looks like water, but there's iodine inside that. Then the iodine goes out through the tubes, and right over the your belly is an X-ray machine, and you can see the dye go in and out of your tubes. And sometimes it flushes the tubes open, so the tubes could have been clogged, and this procedure actually rinses the tubes clean, and the pregnancy rates go up pretty good after that. So that's how an HSG is done. It's usually done right after you're done bleeding, usually from the 5th day to the 10th or 11th day. I recommend taking an antibiotic the day before, the day of, and the day after the X-ray. Not all people are given antibiotics by all doctors. Usually you can take a Motrin pill an hour or two before the X-ray, so it's not so crampy afterwards. Okay, let's see what else we got here. When they're doing IVF, what are the guidelines to try for twins? And how do you decide or when to transfer 2 embryos? Generally, if a patient is under her early 30s, we really recommend only putting 1 embryo back at a time, unless it's a really special situation. 1 embryo, a good embryo in a younger person has a good pregnancy rate, and we rather not put someone at risk of having twins because they all, usually, not all, but almost all of them deliver early. Twins end up going to the neonatal intensive care unit more than singletons, because they're smaller babies have bigger problems than normal sized babies. Just imagine you have 2 babies in there, so they're smaller, they have smaller organs. And so we generally try to avoid creating multiples unless it's a special situation. Okay. Do women gain a lot of weight when they're on these medications? No. So those medications do not contain any fat. They do not slow down your metabolism, but when people gain weight, which I don't really hear that often, but it may be due to stress. It's a lot of stress going through all this. And I recommend everybody seek out some form of counseling for stress reduction. I think seeing a psychologist, a social worker, psychiatrist, talking to a friend, anything to reduce the amount of stress. However, sometimes it can backfire when you talk to a family and friends and then they're asking you about it all the time. So it's better really sometimes to see a professional. This is probably one of the most stressful things in medicine next to having a cancer diagnosis. So if you're feeling stressed, that is normal. And you're not alone. Probably, a lot of, 10 to 20% of reproductive age couples have problems. And a lot of them don't even seek any help and they wait too long. So don't wait too long, especially if you're in your mid 30s or older. You want to seek out solutions or answers sooner than later. I have a question here. What is the oldest age you accept a patient seeking to do IVF? Well, generally someone who is older. So what is older? Someone who's 45 is much younger than me. So, I don't think that's that old, but as far as egg quality, it is getting up there. So someone in their early 40s, we would attempt to do IVF, but once they're over 43, 44, 45, that person should really consider using an egg donor. So when you use an egg donor, you're going to buy eggs from a commercial egg bank. You can see pictures usually of these donors. You can read all about their medical history, their genetic history as far as their parents, what race they are, the grandparents on each side, a medical history. They're usually students that are trying to make some extra money to get through school, medical students. And a lot of these people have a good heart. They want to help other couples. They do get paid. They make about $7,000 or $8,000 to do this. And it costs about $15,000 to buy these about 6 eggs from an egg bank. So if you use eggs from an egg bank from a younger woman between 20 and 30, your pregnancy rate is going to be really high, like between 60 to 70% per attempt. If you use eggs at 43 or 44, it's going to be about 5% chance. So, it's just getting comfortable with the concept of using someone else's eggs. But once those eggs are fertilized and they're put in your uterus and you deliver that baby, nobody asks any questions. It came out of you. You're the mom. And it's completely anonymous. So I just don't like seeing people trying to use their own eggs when they get, after they keep having failed attempts and they're into their mid 40s. It's really not suggested. I know there's places out there that will offer IVF, but the pregnancy rates are very, very low. Okay, another question. Can you explain what a duplicated uterus is? Okay, so let's go back to this picture here of a uterus. So you can see this is a uterus, but I'm sure you can all see when a woman is an embryo, when she's a fetus, a few weeks old and up to a few months old, the uterus is actually, there's 2 of them and they're on each side and they come together and they fuse in the middle and they create one whole uterus. Sometimes that process is not completed. And I might have a picture of that actually. Let's see. Here we go. Perfect. So these are different types of uterine anomalies. So you can see, here's a kind of a uterus that has 1 chamber with 2 tubes. Here's one that has like 2 sides, but this is not really normal. Here's these are the most common ones. It's called a bicornuate uterus. You can see it looks kind of like a heart shape. And then you have what's called a septated uterus, where it's 1 uterus, but there's a septum down the middle. These are easily repaired. They're associated with miscarriages. So the way we remove that is we take a little telescope, we go from below and remove this septum. It's like a flappy piece of tissue there that comes out really easy. This is a woman that has just a little bit of a septum. So septate and bicornuate are the most common. Then you have double uteruses like that with actually 2 cervixes. I had a patient once who had a baby on this side and the other time she got pregnant was on this side. So That's just part of nature and how people, but these are rare. Do we do hysterosalpingograms in the office? We do have a surgery center next to my office that we can do the hysterosalpingogram. And we also do in the office, we just started doing this. I used to do it, now I'm back to doing it again. It's called FemView. And what it is, it's bubbles in water, and we do an ultrasound. So actually we did one this morning, and we see these little bubbles go up into the uterus and they go out each side. And we can see the bubbles go through, and we know that the tubes are open. And it takes about 5 minutes or less. It causes a little bit of cramping, and I tell people to take a Motrin or two about an hour before, and it works great. And like the hysterosalpingogram, the FemView with the bubbles and the saline, they both rinse out the tubes. So there is a benefit of doing that, because you may just get pregnant by cleaning the tubes out. Here's another question. Are you an OBGYN also, and do you deliver babies? I do not deliver babies, but I am also an OBGYN. So first I had to become an OBGYN. That's obstetrics and gynecology. And then after that, you know, I could just practice that, or what I did was I went and I did what's called a fellowship. It's a few more years, and you only do infertility type of treatments and evaluation. So yeah, I don't deliver babies though. Okay, we have another question here. Are there any side effects? Is there any side effect over the operation of opening the testicle? Okay, for the non-obstructive cases. Okay, I do not do that surgery. A urologist does that surgery. As I just said, I'm a OBGYN background. I do gynecologic surgery. Like today, I just took out a bunch of fibroids, which are these big, I actually had a big tumor and a few little ones. You need to go to urologists and ask that question. Generally, you know, they're pretty they're not that complicated with bad outcomes from what I've read. I don't, as I said, I don't do them, but you know, we send people to Dr. Eric Seaman up in North Jersey. We have in Dr. Pierre, I got a mental block right now, but there's a couple doctors that do these procedures, and locally in the Ocean County and Monmouth County area too. So, you know, they do it in our office, in our surgery center. So I've actually seen, you know, these guys come back and no one's ever complained about any kind of bad outcomes. What is an SHG is a question we have. And why would you need to do this? So SHG, it's a little different from an HSG. I know it's confusing. So an SHG is very similar to the other one. It's just, but the difference is you're just putting saline in the uterus, and then you look at the inside of the uterus once the uterus expands from the saline. And what we're looking for are polyps or fibroids or any abnormalities that may prevent an embryo from sticking to the lining of the uterus. So that's why we do it, especially if people are going to go through the process of in vitro. We want to make sure everything's perfect on the inside of the uterus before we do that test. That's why. Here's another question. Is a tilted uterus an issue for fertility? So I do get this question a lot. So tilted means the uterus normally tilts forward towards the bladder. The uterus can also tilt backwards towards the backbone. So 2 out of 3 women, it goes forward, and 1 out of 3, it goes backwards. And they're both normal. However, in some cases, women's uteruses that tilt really far back, and they're stuck there because of what's called endometriosis, that could be a clue why that person has endometriosis, which is scarring of the inside of the pelvis, which pulls the uterus backwards. So, but most of the time, 99% of the time, the backward tilted uterus is there normally, naturally, and it's not an issue for fertility. Here's another question. That was me this morning. Thanks for making it work out. Oh, okay. I guess the FemView, right? Great. Here's a question. SHG is needed even if you have your tubes tied. Yes, because if your tubes have been tied, now you need to do in vitro fertilization. So before you put your embryo back in your uterus, you want to make sure the inside of the uterus is normal. We don't really care about the tubes anymore. Now we're just concerned about the structure and the interior of the uterus. That's why the saline histogram, the SHG, is important. Okay, I hope I answered that question for you. Okay, I think we went through all the questions so far. So I'm going to ask everybody a question. I'm going to do a poll. Okay, let's start with what languages does everybody speak out there? So I'm going to launch the poll. I just want to get a general idea. And please answer the question and let me know.
It's anonymous.
What's that?
It's anonymous, the question.
Yeah. Oh, this is all anonymous, by the way. I don't know who you are. We're just curious what are. Okay. Okay. Thanks, everybody. And it's going to do another question. What is your level of understanding of the topic that I'm discussing? Are you completely green? You don't know anything? You have some basic knowledge? You have a solid background, or you're an expert? So I'm going to launch the poll and you tell me how you feel about what we've been talking about. What's your level of knowledge? Remember, I don't know who you are, so don't feel bad about not, answer any way you want to. I see some of you have some knowledge, that's good. And some of you have a solid background, and we have an expert, great. Okay. Let's see, let's ask another question.
You can share the results.
Oh, I can share those results. Let's see, I already skipped that part. So let's get into like ages. How old are you? Okay, just going to get a general idea of age groups. Okay, most of you are between 30 and early 40s. Okay, most of you are. And I'll share those results with you. Okay. And not everybody's answering these questions, I can see, because we have a lot more participants. Let me see if we have any other questions while we're here.
You don't want a question. You just hit answer live, like that. You.
Okay.
So you don't get confused.
Okay. So the person that's 43, your question about 43 is sort of like getting towards the end of maybe giving another try or two, and then if not, move on. How do you use Omni Trope in conjunction with IVF? So Omni Trope, for those that don't know, is growth hormone. And for women that are really what we call poor responders or don't do so well, there are a few studies out there that show that the use of growth hormone does improve pregnancy rates. So we usually give it during the stimulation period of the cycle, those first few days, once you begin your injectable drugs, usually up until the time you're getting ready to have a trigger shot. So that's how we use that. I believe Omni Trope is about $500 to $1,000 per attempt. Okay. And then I can. Okay, let's see. Hang on. Where is my cursor? Here. Hold on. Let me come back here. There we go. Yes, and for those that had video telemedicine consults with me, and are ready to get started with treatment, we do want to see you eventually before you get started. It'd be a good idea to review everything before we move forward. Okay. And I have another question here. How does AVI Drill work? So AVI Drill is the shot that you take to make your egg come out the following day, which that's ovulation. So AVI Drill is a one-time dose, and it's actually AVI Drill is actually HCG. It's pregnancy hormone. Interestingly, pregnancy hormone is very similar to LH hormone, and the ovary thinks it's LH, so the egg is released. So it's one of those interesting things in physiology. So, okay. Another question here. How long since having a baseline blood work would you say you would have to wait to do IVF? Well, once we start the baseline, you usually can start right away. Now, I don't know what you mean by baseline in terms of, we do also what's called prenatal blood work. That's to check everything else, like your thyroid, your blood count, your liver function, your kidney function, some other things. That's not baseline. That's just prenatals. But once you're ready to start and you do your day 3 bloods, it's not always day 3 either, but generally we call it day 3 blood work, you're usually ready to start right away. There's another question. How long can IVF typically take if your tubes have been removed? Well, having your tubes removed is a reason to do IVF. And if your tubes are removed or you've had them ligated or cut, you can begin IVF, within a month or 2. So there really is no long delay at all. Okay. If a woman is doing IVF treatment, how long does she have to take injections before? And are there any negative side effects of these injections? Okay, so you usually take the injections for about 10 days, plus or minus a couple of days. During that 10-day period, we need to see the day you start, and usually about every other day. Sometimes the first segment, you can go maybe 3 days. It depends. But usually once you start, you're into it, it's about every other day. So it's about 5 times you need to be seen for monitoring. That means measure your follicles, draw your blood, and see if the medication's working correctly. And the negative side effects, well, there are not that many, but if you have a situation called polycystic ovarian syndrome, PCO, we don't want you to mature 100 eggs or 50 eggs or even 20 eggs. 20 is getting up there because that's called hyperstimulation syndrome. So we want to prevent your ovaries from getting overstimulated, because that can lead to fluid retention and a swollen belly and fluid imbalances, and this could lead to issues. Generally, we try to avoid that by seeing you periodically to make sure you're not getting too much medication. Of course, we want to get a fair amount of eggs, but we don't want to make you sick either. So that's one of the side effects of too much of the injectable drug. Okay, then someone wants to know if I will address gestational carriers. I can address it right now, and the process of how our office supports it. So we do not find gestational carriers. We work with the gestational carrier services throughout the United States. There are a couple in New Jersey, California, they're out there, and they will find a carrier, and the carrier, you'll meet that carrier. So a gestational carrier is a woman who carries a pregnancy for another woman. Say, for example, there's something wrong with that person's uterus, or they're born without a uterus, or they have medical problems, and it's not recommended for them to be pregnant. So we work hand in hand with the gestational carrier group that finds the carriers. They pay the carriers. They do all the legal work for the carriers. These are very professional people. They know what they're doing, the ones that we've worked with. and they find good quality people to carry the pregnancy. Yeah, okay. Okay, we have another question here. This lady had an HSG X-ray about 2 years ago to check her tubes. Would I have to do another one before she starts her fertility process? No. If you've had one and it shows your tubes are open, and you've had no complications since then, like surgeries or other complications then you do not need to repeat that. I understand. Most people don't want to repeat that. It is a little crampy. So the answer is no, you don't have to do that again. I try not to repeat things. Try to move people forward and get them to their end goal faster without repeating. There's another question. Do you ever use Clomid, I guess, with an IVF cycle, even if a woman ovulates normally? So yes, we do use Clomid, and we use injectables, and sometimes we use them together. Sometimes we use just Clomid alone, and a little bit of injectable. The purpose, it's not, if you're ovulating normally, that's really not the issue. The issue is trying to get more than one egg. So you do want to get several eggs if you can. Now, if you're 23 years old, and you're really young, and your tubes are no good, and you're doing IVF for that reason, you know, some people do what's called a natural cycle IVF. You just remove the one egg, fertilize it, and that's it. That we can do. We can do that at any age. It's just recommended to try to get more eggs if you're going to do IVF. But it is possible. Someone here is 42 years old. Which is the best fertility option for her? So, you know, if you know, I don't know anything about your history or what the other issues are, but generally, if you're 42 and you want to get pregnant, IVF is the answer. That's the best answer. Now, what if the reason you're not getting pregnant is because you don't ovulate? Well, maybe you want to try something to help you ovulate first, and then see if that works. But you know, if you ovulate, you get regular periods, and everything is normal, and you're 42 and nothing's worked, IVF is definitely the best answer. And if you went and got 20 opinions on that, I would guarantee you 19 fertility doctors would agree. Here's a lady that says she's trying 2 years to get pregnant and everything seems good. Why am I not getting pregnant? Well, we need to check all the other causes of infertility, right? I mean, there's, you know, did your husband get checked? Did you have your tubes checked? Did you, let's see here. Did you, are you ovulating? So there's more to the story. You know, as I mentioned in the slide up here, there's other reasons, right? We talked about tubal factor. Are your tubes open? Male, has the male been checked? Do you ovulate? Ovulatory issues. Have you had an ultrasound to look at your uterus? Are there fibroids? Are there polyps? So you need to answer just a couple of these basic questions. It's very simple. Drop off a semen analysis, go get an x-ray, check your tubes, or you can do the FemView. That's easy too. That's just with saline and a couple of bubbles. Do an ultrasound. So you need a reason why. And if you don't have a reason why, then start thinking about in vitro fertilization and IUI. You know, listen, we also haven't talked about laparoscopy. You know, a laparoscopy, let me show you what a laparoscopy is. So, you know, would be looking inside the pelvis. Here's a uterus, and here's a tube, and here's blue dye coming out of the tube. That's confirming that the tubes are open. So, you know, that's done through a telescope through the belly button called a laparoscopy. So I don't have a picture of a laparoscopy, sorry. So let's see, do we have any other questions? what can we do to improve egg quality? So, well, number one is egg quality usually is a reflection of the age of the person. So the older you get, the egg quality diminishes, and it's the chromosome. The chromosomes are the problem as you age, and you really can't reverse that. There is some evidence, however, that if you take antioxidants, that can improve egg quality, such as CoQ10, vitamin C, vitamin E. There's lots of antioxidants. Vitamin C is the most famous one. CoQ10 is also good. So those have been shown to be somewhat helpful. But you really also don't smoke, avoid alcohol, stay away from toxic environments. Hope I answered your question. Here's a question about sperm volume of 3 mils, which is normal, and 39% motile good sperm count. Could that be a reason for infertility? So 39% motile, that means what percent of the sperm are moving? 39% is not terrible. I mean, it's a little on the low side. I would repeat it if I were you. But your sperm count is good. So if you have a good sperm count and almost 50% are moving, it might be a problem. You know, there could be other issues like we talked about. Has anybody checked your wife's tubes? Does she ovulate? Did they do an ultrasound on her? Is her uterus normal? Are her ovaries appear normal? Is she a smoker? Is she had any pelvic surgeries? Anything could possibly have happened to her tubes? So I want to focus just on this sperm count right away. But however, what you could do is a simple test would be you can do an IUI, inside uterus insemination. So assume your wife did do all those tests and she is normal, and the only issue is a little bit of a low motility, you can try an IUI. So yes, it is, but always repeat a semen analysis just to make sure you're not missing anything. Keep those questions coming. Should all men get tested, not just the women? Absolutely. All men should be tested unless it's very obvious that she has an issue. For example, let's just say a guy's young and he's healthy and his wife is young and healthy, or they have no issues, but she never gets her menstrual cycle. Obviously, she's not ovulating. The egg's not coming out. So you could work on fixing that first and try that a couple months. But it's no big deal to drop off a sample at our lab or any lab for that and just get tested. Remember, men make up almost 4 out of 10 of the problems. So it's 40%. That's a lot. So yes, I do think a man should be tested sooner than later, unless it's an obvious situation like his wife doesn't have a normal period. And if we can get her to ovulate and she's not pregnant after 1 or 2 or 3 months, don't wait too long. You should be tested. Here's a question. On the day of the IUI, she was told that her eggs weren't mature. Could that be the reason for that? What could be the reason for that? Well, sometimes, and not that often, but sometimes when a patient's being monitored, I was telling you about the ultrasounds previously, and how you measure the follicle getting bigger and bigger to see when the egg is ready. And the estrogen levels going up and up and up, and that gets higher as the egg gets mature. Sometimes the trigger, the AVI Drill shot, someone had asked about earlier, is given too early. So the egg may not be mature. We generally have some rules, general guidelines we follow. We like an estrogen over at least 200 for one follicle, for one mature egg. However, I have seen women with lower levels that do get pregnant as well. So it is possible it wasn't mature, but it's not that common to see that. What is a good healthy sperm count? Okay, so sperm count should be about 16 to 20 million sperm cells per milliliter. Okay, and there's a way the laboratory technician evaluates that. They take a small drop and they put under a slide, and under that slide, they count just a small area. They obviously don't count 20 million cells, but they do a little calculation and they figure out what the count is. So you should have about 20 or more, 16 million, really more than 16 million. Okay. What is ICSI? Okay, well, interestingly, I have an ICSI picture right here. So let's look at that picture. So ICSI is where this is an egg, this is a needle, and this needle has, I don't know if you can see it, but inside the needle, there's a sperm in here. And the sperm, the needle punctures through the shell of the egg, and the needle is placed inside the egg. And the sperm then gets in there and fertilizes the egg. So that's ICSI. And this was pretty much developed back in the early 90s by a physician in Belgium. This pretty much cured male factor problems. So if a man has even the worst sperm count, like very, very low count, this can help people get pregnant. So this was a really huge advance in our field. Remember, the first baby born through IVF in vitro was 1978. So this was like, 14 years later, they added this to our treatment arm. So this is a really an amazing thing. My embryologist is very good at doing that. She's, we call her the ICSI queen. She's very good at injecting sperm into eggs. Okay, so that's the question about ICSI. I'll answer that. What is mini IVF, and do you do that? Yes, we do that. So mini basically means small amount of medications are used. So as I was saying earlier, the more eggs we get, that means the more embryos you get, and hopefully out of those group of embryos, you're going to get 1 or 2 good ones. Sometimes we can't get that many eggs, no matter what we do, even if we give you 10 times the amount of fertility drug. So more medication does not mean it's better or you're gonna have a better outcome. Sometimes less medication or mini IVF is better. So that would be just small amounts of medication. Sometimes we do a combination of oral medications and injectable medications in small amounts. And you do see pretty good results. Okay, so that's, hopefully we answered that question. And mini IVF also saves you money because you're not spending so much money on drugs. We will do webinars about once a month. This is, okay. For women who don't have regular cycles, what can or should be done before beginning fertility treatment? Well, we just want to make sure that they do not have any thyroid issues or other pituitary hormone issues like elevated prolactin levels. So we want to make sure it's not an endocrine problem or some kind of small little growth in the pituitary that could be preventing normal ovulation. So that's number one. That is to see nothing bad is happening. Once we make sure those hormones are okay, then we can look at other factors like height and weight. Would losing 20 pounds help? It's been shown that women that are overweight that don't ovulate regularly, if they lose only 5% of their body weight, they will start ovulating. So that's also a good approach before moving on to injectable drugs or oral drugs. Okay, is it normal to ovulate day 16 or 17? Yes. So what is normal? What's a normal cycle? So anywhere between, so from the first day of a period to the first day of the next period is usually about 30 days, but the range would be like 25 to 35. But most women are like 28 to 32, so around 30. So the rule of thumb is the day you get your menstrual cycle minus 14 days is the day most women ovulate, plus or minus a day. So if a woman has a 30-day cycle, 30 minus 16, 30 minus 14 is day 16. So that's perfect. That's fine. That's good. So you have it, that's normal. Somebody asked, what's the average cost for medication? If it's in vitro fertilization, it could be anywhere from about $3,000 to $5,000. Unless you do mini IVF and you're younger and you don't need too much medication, you could try Clomid and injectables, but it could still cost around $2,000, $2,500. Okay. Okay. We don't use the InvoCell, and that's basically using a placing the embryo into the vagina as an incubator versus an incubator in our office. Will you address gestational carriers? Yes, we talked about gestational carriers already. Okay. Main causes of miscarriage. So the main cause of a miscarriage is the most common reason women have a miscarriage is because they're getting a little bit older. But even if they're younger and they have a miscarriage, it's usually because there's something wrong with the embryo. So the sperm, like kind of in this picture here, but just imagine a sperm goes into the egg. The sperm has 23 chromosomes. The egg has 23. You put 23 and 23 together. Humans are 46. Sometimes there's 45 chromosomes, or maybe there's 46, which with a little extra piece of another chromosome. Those are chromosome problems, and they become more common as you get older, but they still happen when you're younger. So that's the number one cause of miscarriages. And you can't do anything about it. It's just part of nature. Okay, I'm just reviewing these questions. What is the oldest age? Our oldest age to do IVF is 45, unless it's some very special situation that they want to talk about. Someone asked, okay. How do you prepare your body to accept an egg if you will be getting a donor egg? Well, so people that use donor eggs typically are going to be a little bit older. I recommend those people start to do some cardiac exercise, get your heart rate up, because when you get pregnant, your blood volume almost doubles, so your heart works harder. So, you know, typically women are having pregnancies in, you know, their 20s and 30s. You know, if you're 20 years beyond that, you know, you want to work on, you know, being healthy, you know, having a good cardiac reserve. So work on bike riding, walking fast, maybe light runs. And that would be a very good way to do that. Also, that would be the best way. And eat healthy and avoid alcohol and do not smoke cigarettes. Okay, I think I'm going through all these questions. What do you do when you have unexplained? We talked about unexplained infertility. Someone has a question here about ectopic pregnancy. That means getting pregnant in the fallopian tube. So when someone gets pregnant in their fallopian tube, that's dangerous. Luckily, most of the time it naturally dissolves on its own. Sometimes the tube can actually rupture and you can bleed internally, and that can be dangerous. And sometimes you just need surgery. However, in the last 20 years, a lot of people use what's called methotrexate. That's an injection of a anti-cancer drug. and it's only a one-time dose. Sometimes you need 2 doses. And what it does is it stops the embryo from growing in the tube. So it dissolves it. So that's a treatment for a tubal pregnancy. So why do you get a tubal pregnancies? Well, there's lots of reasons, but one is could just happen naturally. And, the embryo takes about 1 week to get down through the tube to get into the uterus. And sometimes it just gets stuck there. Sometimes there's endometriosis where your tube can be kinked, or you could have prior pelvic surgeries where your tube is not so functional. So these are reasons. Prior pelvic infections like chlamydia that can also damage tubes, which could lead to tubal pregnancies. So these are all reasons why you get pregnant in the tube. Okay, looks like we answered all the questions. Okay, we got a new one. Okay. What is the treatment of the female's fibroids or polyps? The polyps are removed through what's called a hysteroscope. It's a little telescope through the cervix into the uterus, and fibroids, depends where the fibroid's located. Like today, I had to open up the belly on this, like a C-section cut, and I took out a fibroid about the size of a grapefruit and about 3 other ones the size of the size of an egg. They were pretty big. So she needed a big incision. Sometimes you can do it through a laparoscope, but normally we don't do that much anymore. Or sometimes you can remove it through a hysteroscope too. So it really depends on where it's located and how big it is. If I go to a fertility doctor, do I also need to see an OBGYN every year? You need to really get your pap smear every 2 years. It depends on what age you are, of course. Once you're pregnant, we send you back to an obstetrician and they'll deliver the baby. Okay, it looks like we have answered all your questions and it's already 8:06. Wow, time flew by. Thank you all so much for stopping in. I appreciate all your questions and hopefully those questions helped other people. And we'll see you next month. Have a great night, everybody. Bye-bye. It's